you, Professor Amin.
Thank you very much, Dr. Farid, for this nice introduction and for the kind invitation. Please just let me begin by a few words in Arabic, because Arabic is the language of my heart. حقيقة هو شرف كبير لي اللي حظيت به في أن أكون بين إخوتي وأهلي وأحبتي في ليبيا، وأشكركم جزيل الشكر على هذه الثقة، وأتمنى أن أكون عند حسن ظنكم. وحقيقة لا أقدر أن أفوت الفرصة دون الترحم على روح الفقيد الدكتور طاهر شركس، الذي كان رفيقا لي ونعم الرفيق في رحلة باكستان مع صديقي الدكتور يوسف كرايم وصديقي الدكتور حسن بادي. كما أريد أن أشكر صديقي دكتور حبيب بسباس أستاذ طب أطفال بالمنستير، الذي مكننا تقنيا من تنظيم هذا الملتقى الافتراضي. Now I will return to English and I will begin my lecture regarding esophageal atresia. This will be a basic lecture, as the target public are residents, and I will begin by a quiz, and I will ask our dear residents to make their choice to respond to the quiz, and after we will make a short discussion. Dr. Farid will show you after a few interesting videos regarding esophageal atresia, and we will end by a discussion. Meanwhile, if you have any question, please put it in the Q&R section, not in the discussion section, and we will respond to these questions. Let's begin by our quiz. I don't know if you see my screen. Dr. Farid, you see my screen?
No, still no. Yes, now yes.
Okay.
Okay.
So this is the case of a male newborn transferred to the NICU. In his history, we find a mild polyhydramnios discovered in the last fetal ultrasound. This patient presented shortly after birth excessive secretions with cough. The orogastric tube could not be advanced past 11 centimeters. So you decided to perform a plain X-ray with radio-opaque gastric tube, and you noticed that this gastric tube arrested at the level of the second or third thoracic vertebra. So you highly suspected the diagnosis of esophageal atresia. Here we will begin by our first question. Did this X-ray establish the diagnosis, or do we need more investigations to confirm the diagnosis? Okay, so the majority chose it, the first proposition, and only 2 choose it, the second proposition. So here in this case, this plain X-ray is sufficient to establish the diagnosis. There are some surgeons that prefer to perform themselves this intervention to push the gastric tube, and if they have the same constatation, they will indicate the surgery. Please do not perform any opacification. This is not useful. It can also be harmful for the baby. Sometimes you can suspect a pharyngeal iatrogenic perforation. Pharyngeal iatrogenic perforation is observed in some difficult case of intubation in high premature babies. And here, the clinical features will be similar to the clinical features that you have in esophageal atresia. But you will notice some strange position of the gastric tube that is too low or too high or eccentric. So in this case, a profile can be very useful to rule out a pharyngeal iatrogenic perforation. So here we finish it with our first question. Now we will go to the second question. When you observe this plain X-ray, and with remembering the gross classification, which is the most used classification in esophageal atresia, what are for you the most likely types of esophageal atresia? So, excuse me. I will launch just the questions. Okay, you have 10 seconds to make your choices. It can be more than one choice. Okay, perfect. We have good residents. Huh? So here it's true. The right answers are C and D. And here is our second message. X-ray is really very useful because it will confirm the diagnosis. And the second information, it will give you an idea of the type of esophageal atresia, and especially the presence or not of distal tracheoesophageal fistula. And this is proven by the presence of intestinal gas. Excuse me. Do you see my screen again?
Yes, Dr. Amin, it's clear.
Excuse me. So the X-ray will give you precise information. It will confirm the diagnosis of esophageal atresia. It will give you also great information of the presence or not of distal tracheoesophageal fistula by the presence of intestinal gas. So if you have intestinal gas, this should be type C or type D, in which we have a distal tracheoesophageal fistula. And this is a very important information as this will influence your strategy. If you have type A or type B, here the gap is very important and you have a particular strategy. But if you have type C or your type D, here you can perform a primary anastomosis. The other information that you can have from the plain X-ray is the associated malformation. You must know that esophageal atresia occur in the early period of gestation. And whenever you have an early accident, you will have a high rate of associated malformation. So when you will observe your plain X-ray, you should also search if there are any anomalies of the ribs, any anomalies of the vertebra. You will see the cardiac silhouette, you will see the lungs, and you will see if there is any atresia, duodenal atresia or intestinal atresia. But not only the X-ray will make you research for this associated malformation. And here will come the third question: how you will proceed with the baby's clinical and radiographic evaluation to assess for this malformations. So here also you can choose more than one proposition. Please make your choice. Okay, very nice. So all the responses are right. So B, C, and D. We must, of course, do our physical examination. Because, you know, associated malformation are seen in 30% of cases. It can be cardiovascular, vertebral, digestive, or urinary malformation. This malformation can be seen in associated syndromes. You must know that there are at least 15 syndromes that were associated with esophageal atresia, and Vater or Vactral syndromes are probably the best known. They represent approximately 20% of all esophageal atresia. And when we have at least 3 of this malformation that we will see below, we will speak about Vater or Vactral malformation. So I remind you just Vater, V for vertebral, A for anal, T for tracheal, and E for esophageal, and R for renal. And for Vactral, we will add C for cardiac and L for limb. So here, what we must do, we must perform musculoskeletal examination to see the rib cage, the spine, the upper limbs. Are there any radial anomalies, exadactyly, syndactyly? We must examine the anus. Of course, we must perform heart and lungs auscultation. Of course, the X-ray, we just spoke about the X-ray. The echocardiogram is very important, and the echocardiogram should be done before the surgery. This is very important for 2 reasons. First of all, for anesthesia considerations, but also to check the laterality of the aortic arch. Usually, the aortic arch is situated in the left side. So when we will perform a right thoracotomy, we will not have any problem to perform our primary anastomosis. But in 5 to 10% of cases, we can see a right aortic arch, and here, a right thoracotomy will be problematic to perform our anastomosis, and most of the surgeon will prefer to do, in this case, a left thoracotomy. Also, we must perform an abdominal ultrasound to check if any malformation, and especially renal malformation. So in this case, for this patient, the physical examination was unremarkable. The echocardiogram showed a left side aortic arch and insignificant ventricular septal defect. The abdominal ultrasound showed a pelvic urethral junction with mild dilation. So you decided to perform a right thoracotomy. Here, in this case, will you perform a rigid bronchoscopy just prior the surgery? Yes or no? So please make your choice. Okay. So the majority choose to not perform a rigid bronchoscopy prior the surgery. Here, I can tell you that if possible, perform a rigid bronchoscopy. It will be very useful. First of all, it can help you to assess a proximal fistula. Proximal fistula is difficult to discover otherwise. After surgery, you will have a patient with problematic complications like recurrent bronchopneumonia. So it's always better to assess if there is any proximal fistula. Also, this bronchoscopy can help you to search for other malformation like tracheomalacia. And bronchoscopy can help you to have a prediction for the gap between the two pouches. You know, even if you have a distal tracheoesophageal fistula, this do not mean that you can perform easily your anastomosis. Sometimes, even in type C esophageal atresia, you can have a high gap between the two pouches. And for example, if you have this distal esophageal atresia that is in the carena, this means that the gap is high. You will have a long gap esophageal atresia. Other things that can help by doing the bronchoscopy is to put a guide wire in the distal fistula, and this can help you to perform your surgery more easy. So if possible, perform it, but this needs expertise. This is not easy. This needs also adapted material. So in this case, it was not possible to do a bronchoscopy, and you performed your surgery. So you will detail the surgery after. So you closed your tracheoesophageal fistula and you performed your anastomosis. And after, the question that may be asked, how many tubes will you place during the procedure? So here I will ask you also to vote for the numbers of tubes that you will put during the procedure after performing your anastomosis. Okay, so we have mixed responses, and I must tell you that there are no right answer. All the propositions are right. It will depend on your experience. Personally, I put a chest tube near the anastomosis in case of fistula, and I will put a transanastomostic gastric tube, because this transanastomostic gastric tube will help me to feed the patient early, 2 days or 3 days after the surgery. And also it can be useful in case of a fistula. Some surgeon will prefer to put only a chest tube. Other will put also 3 tubes with another tube in the upper pouch to make a suction of any saliva and to enhance the recovery of the anastomosis. Now the patient is operated and the anesthesiologist is happy, and he proposed to extubate the patient on table. Will you accept to perform the extubation of the patient or not? So please make your choice for the on-table extubation. Okay, so the majority choose it no. They will not accept to perform the on-table extubation. And I think this is the good response. You know, the main concern regarding extubation is to minimize the chances of emergent reintubation. And this may lead to disruption of the fistula ligation or for the esophageal repair. Therefore, on-table extubation is generally discouraged. The patient is best transferred to the NICU intubated and then subsequently extubated within 72 hours, once extubation criteria are met. This is very important. Try to not extubate your patient very early. Will be very harmful, especially, thoracotomy is very painful, and this can damage the respiration procedure. Now, the patient is doing well, and you are thinking about the oral feeding. So here also I will ask you, what are your choices regarding the post-operative feeding? Will you choose to feed your patient after at least 2 weeks, or just 1 day after the surgery, or after performing upper GI study contrast 5 to 7 days after surgery? Okay, so the majority chooses to perform or to begin feeding after performing upper GI contrast study. This is the right response. And I will tell you, our experience in Monastir, we always, before realizing the upper GI, we should, of course, observe the chest tube. If there is saliva, this means that there is a fistula. Better to postpone your upper GI study. And sometimes, even if you don't have saliva, what we are doing in Monastir is we are doing the methylene blue test. This means that we will give to the baby 1 to 2 cc of methylene blue, and after we will see if there is any blue in the chest tube. If there is blue in the chest tube, this means that there is a fistula, and better to postpone our opacification. Okay, so this patient had an upper GI study that showed mild anastomotic stenosis without fistula. So we removed the chest tube and we started oral feeding without incidents, and the patient was discharged at home with anti-reflux treatment. 1 month later, this patient reconsulted for feeding problems, so we decided to realize another upper GI study that showed you this stenosis, this anastomic stenosis. So what would be your options? Redo surgery with resection, or balloon dilation, or anti-reflux surgery? Okay. Here, the best option is to perform balloon dilation. It's true that in few cases, anti-reflux surgery can be useful, but with the medical treatment, it should be okay. But sometimes in reflective cases or reflective stenosis, anastomotic stenosis, here we will need to perform anti-reflux surgery. But in the majority of the cases, balloon dilation should be sufficient. So this patient, we did for this patient balloon dilation with 2 sessions without recurrence of stenotic anastomosis. The last question is, how long should follow-up remain for this patient? Will you choose to follow up this patient till the walking age, till the age of 10 years, till the age of 15 years, all his life? Okay, we have very mixed answers, but trust me, the right response is all his life. This kind of patients can have serious problem of swallowing or of recurrent bronchopneumonia even in the adulthood. And this is very important. Now the question or the goal for this patient with esophageal atresia is not only to make the patient survive, but to make the patient survive with a good quality of life. So you should make this patient live with a good life, and this patient should be followed by a gastroenterologist after for all their life. And this is very important. The pediatric surgeon should be available to treat the esophageal atresia, but also to treat the complications of esophageal atresia. And for this patient, he is now 4 years, he's doing well, but he presents sometimes some respiratory problems. Now we finish it with the quiz. I hope that with this quiz will be useful. Now I will try to make a little discussion with the key point in esophageal atresia management. As you know, esophageal atresia is defined as the interruption in the continuity of the esophagus with or without tracheal fistula. This is a life-threatening situation. That's why it's an emergency for treatment. You must know that the incidence of esophageal atresia is about 1 for 3,000 births with a slight male predominance. Regarding the pathogeny, esophageal atresia is related to abnormal separation of the gastrointestinal and respiratory tracts. This etiology is unknown, but we know that this is an early anomaly that occurs between the 24th and the 36th day after gestation. So this explains why we have a high rate of associated anomalies. There are many hypotheses to explain this etiology, like viral, genetics, or Texas hypothesis. For the classification, so you know all the gross classification. This classification will depend on the presence or not of tracheoesophageal fistula and also the location of this fistula. So in type A, that is seen in 10% of all the cases of esophageal atresia, we will have no fistula. In the type V, we will have a proximal fistula. In the type C, which is the most frequent, approximately 85%, here we will have a distal tracheoesophageal fistula. In type D, we will have a proximal and a distal fistula. To this classification, we can add the type A. This is the congenital fistula with no interruption of continuity of the esophagus. The associated malformation, we already treated this chapter. For the physiopathology, in the internatal period, we will have, in most cases, polyhydramniosis, because we will have a disturbance of the swallowing procedure. And this polyhydramniosis will cause like a stimulation in the uterus that can cause prematurity. Prematurity is observed in approximately 40% of all the cases of esophageal atresia. Also, this problem of swallowing disorders will cause a low weight for the patient in many cases. Regarding the physiopathology, at birth, we will have symptoms related to the upper esophagus pouch and symptoms related to the presence or not of a distal tracheoesophageal fistula. So, regarding the upper pouch, here we can have the aspiration danger as the secretions and the saliva can go to the bronchi and to the lungs. Regarding the distal tracheosophageal fistula, here we will have the gastric reflux of the gastric liquid in the bronchi, and you know all the corrosive effect of the gastric liquid. This can be very harmful for the lungs. Also, we will have a decrease of the respiratory volume, as a high volume of air will go in the stomach and in the intestine. And also this will cause an abdominal distension, and this abdominal distension will compromise the function of the diaphragm. And as you know all, the diaphragm is the most important muscle in the respiration. For the diagnosis can be done by the ultrasound before birth in approximately 15% to 30% of the cases, by the constatation of polyhydramnios or the constatation of fluid shifting in the upper pouch. And here the importance of the antenatal diagnosis is to plan the postnatal care. For example, the delivery should be planned in a center in which we have a good NICU and also a pediatric surgery department. Regarding also the antenatal diagnosis, now we are speaking about fetal MRI, and fetal MRI really improves the diagnosed accuracy in patient referred to fetal center for suspected esophageal atresia. So fetal MRI can be useful also for the antenatal diagnosis of esophageal atresia. Now, at birth, here we should make the diagnosis by the impossibility to pass a feeding tube into the stomach. This is a mandatory test. It should be done for all the newborn, because we should not see, and we must not see, the aspiration danger or the postnatal drooling of saliva or bronchopneumonia to think about the diagnosis, but we should perform a systematic esophagus permeability check for this babies. And here the diagnosis will be done by a plain X-ray. This means plain X-ray, you must perform an X-ray that takes the cervical part, to the thoracic part, the abdominal part, and even the pelvic part. And you should use a radio-opaque gastric tube for the diagnosis. And here it will be easy, as the gastric tube will arrest at the level of the second or the third thoracic vertebra. As I told you, the profile can be useful, especially if you suspect a iatrogenic pharyngeal perforation. And the other information very important is to see again intestinal gas. For example, here there are no intestinal gas, so here it's type A or type B. This means there is no distal tracheoesophageal fistula, and this will interfere with your management strategy. Also, we must check if there is any consequence in the lungs, like you see in this example. We must check the intestine, if there is any atresia, duodenal atresia or intestinal atresia. And of course, we must check the vertebra. Like you see here, there's two hemivertebra. We must count the ribs, if there is any problem in the ribs, the spine, if there is any scoliosis. Of course, if it's done, we must check if there is any radial anomalies. And also we check for the cardiac silhouette to see if there is any visible malformation. We should not do opacification. This is very harmful. It can harm the baby, and it's not really useful. Now the diagnosis is made. We should perform our pre-operative work up with continuous section of the upper pouch through the feeding tube. The baby is nursed in the intensive care unit. Immediate surgery is rarely required. surely we should not postpone the surgery for 2 or 3 days. We should only postpone the surgery till we will check for other malformation, and particularly to realize, if possible, of course, the echocardiogram, because this is very important for anesthesia, and to check, this is important if there is any right aortic arch that can make your surgery difficult if you will decide to do right thoracotomy. So if this patient presents dyspnea, please do not use mask ventilation. Why? Because if you will use mask ventilation, air will pass in the lungs, but the majority of the air will pass in the stomach, in the intestine. This will enhance the abdominal distension. This will enhance also the pressure in the diaphragm and compromise the respiration. So if needed, here we must perform endotracheal tube, and at the best, this endotracheal tube should be pushed beyond a possible distal tracheoesophageal fistula. And of course, this is, you know, a rule for any baby. You should prevent infection and hypothermia. Now we will arrive to the surgical treatment. Here, as you know all, there are two strategies. Esophageal atresia with distal tracheoesophageal fistula. Here we will perform fistula closure. Primary anastomosis, it can be done by thoracotomy or thoracoscopy. And we can have esophageal atresia without distal tracheoesophageal fistula. So here, normally, the traditional approach is to perform gastrostomy, upper pouch suction or esophagostomy, and after we will perform late anastomosis or esophageal replacement. Let's begin by our first approach. If we will decide to perform a thoracotomy for primary anastomosis, so here it's better to begin by a bronchoscopy. You see here, by the bronchoscopy, we see the fistula. Okay, so here we see the fistula, and this bronchoscopy is very useful. Here you see the carina, and the fistula is situated 2 or 3 centimeters up the carina. So here it's a sign that the gap is not very huge, and you can perform your primary anastomosis. So sometimes if you can put a guide wire in the fistula, this will be very useful in your surgery. So after we will perform our right lateral dorsal thoracotomy by the mobilization of the latimus dorsi muscle, taking care to avoid damaging the thoracodorsal nerve. We prefer to perform muscle sparing by disinserting the serratus anterior muscle along its origin. After we will do the incision of the intercostal muscle along the border of the 5th rib, and here we will try to make an extraplural procedure. So the parietal pleura is swept from the thoracic wall, taking care to not open it. After, we will prepare the azygos vein, which is dissected. The distal esophagus tracheal fistula is freed from the surrounding tissue, and traction sutures are placed at the tracheal and esophagus ends. The esophageal fistula is divided and simultaneously closed, avoiding any blood in the trachea. And here, after, we will ask the anesthesiologist to push gastric tube, so the upper pouch will be stretched, and the upper pouch is freed from the surrounding tissue and dissected in order to pull it down to the lower esophagus. And here you must know that the upper esophagus is very well vascularized. So please enhance as much as possible the dissection of the upper pouch. And regarding the lower pouch, here try to avoid extensive dissection, because this this can compromise the vascularization of the lower pouch, and this can lead to anastomotic leak or to anastomotic stricture. After we will open our upper pouch and we will perform our anastomosis. It's very important to take the mucosa when you will perform your anastomosis. If you will not take the mucosa, you will have fistula. So usually we will begin by the posterior wall with interrupted suture. After we will ask the anesthesiologist to push the gastric tube that will advance till the stomach, and after we will close our anterior wall. After we will put our tubes, this will depend. The chest tube, I think, is mandatory, and we'll close our thoracotomy. Regarding the thoracoscopic approach, so it's we have here the same results, but this will need experience and we need adapted material. I think that Dr. Farid will show you a few interesting videos regarding thoracoscopy. So here I will try to develop some debated points. First of all, why extrapleural approach? Many surgeons are thinking that the extrapleural approach can have benefits, especially if you have a leak, because this will avoid to have mediastinitis. But this seems theoretical. So I think that extrapleural or intrapleural approach are almost the same. Other debated point is the azygos ligation. Now many surgeons prefer to prevent to do any azygos ligation. I think if you have real difficulties to make your anastomosis, don't hesitate to ligate it. But otherwise, if you can prevent this, this would be better because you will prevent any thrombosis accident in the future. For the tubes, we already developed this point in the case discussion. For the results, the mortality range between 15 to 20% of the cases, and this will depend mainly on the existence or not of cardiac malformation. We can see early complications like bronchopulmonary complications or anastomotic fistula. Anastomotic fistula is diagnosed by the clinic, especially the presence of saliva on the tube or the presence of mediastinitis. Most of them are minor and will heal with only medical treatment by keeping the chest tube, by a good nutritional statement, and by antibiotics and the suction of the upper pouch. This can be healed with in the majority of the cases. But sometimes we will need stenting, and especially the covered stenting, or in very exceptional cases, we can perform redo surgery. The other complication that we can see are tracheoesophageal fistula recurrence, gastroesophageal reflux in almost 30% to 50% of cases, and anastomotic stenosis. So for fistula recurrence, you see here some examples of fistula recurrence. We can treat them by endoscopic approach. You can inject glue or any fibrotic agent in this fistula, or also you can use the covered stenting. But in some cases, if there's failure of these techniques, we are obliged to do a redo surgery. This is a difficult surgery. We should begin by endoscopy to put a guide wire in the fistula, and after we should separate the trachea from esophagus and put another tissue between this trachea and esophagus. For gastroesophageal reflux, it's complications that is frequent after esophageal atresia repair, as will compromise the anatomy of the junction between the esophagus and the stomach. It can be treated by medical treatment in most of the cases, but sometimes we will need to perform gastroesophageal reflux surgery. For stenotic anastomosis, in most cases, this will be healed by balloon dilation. It will be sufficient. Sometimes we will need to perform plus the surgery of gastro reflux if there is gastro reflux. And we should especially prevent this stenotic anastomosis. The prevention is done by performing a good surgery, and also to avoid to dissect the lower pouch. If you dissect so much the lower pouch, you can have stenotic anastomosis due to the vascularization compromise. We can see other late complication like esophageal peristaltism anomaly that are observed after swallowing trouble, dysphagia. We can have recurrent bronchopneumonia due to gastroesophageal reflux or due to tracheomalacia. You know, tracheomalacia is a condition where the cartilage that keeps the airway trachea open is soft, that the trachea is partially collapsed, and you see this especially during increased airflow. And the usual symptom is stridor. The patient will heal spontaneously in most frequent case, but sometimes we need to perform other things. So here I will show you a few articles speaking about the complications after esophageal atresia repair. This is a very nice multi-institutional retrospective study of infants with esophageal atresia treated in at 11 children's hospitals between 2009 and 2014. So you see that the mortality was 7.5%. This is in the United States, and was significantly associated to cardiac malformation. And postoperative morbidity occurred in 22% of the cases. So you see that you have a lot of morbidity after tracheoesophageal fistula repair. This morbidity include 42% cases with anastomotic stricture, 23% with anastomotic leak. We have also vocal cord paralysis, recurrent fistula, anastomotic dehiscence. So you see, it's very important to speak with the parents for the probability of having such complication with their babies. These complications factors would depend on the gap between the two pouches, and also will depend on the surgeon experience. Now we will go to the second case in which we have a long gap esophageal atresia. Here, a very important point. Long gap esophageal atresia is not type A or type B esophageal atresia only. The most practical definition of long gap esophageal atresia is the impossibility to perform primary anastomosis. Sometimes you have type C or type D esophageal atresia and you cannot perform primary anastomosis. So it's a long gap esophageal atresia. So here is the strategy. The traditional strategy is to perform initial gastrostomy with suction or esophagostomy. And after, we have two options. Some will prefer to perform replacement using the colon or the stomach. The stomach can be pulled up and be used as esophagus, or you can use a tube of this stomach. The other option is to use the native esophagus. The native esophagus is clearly the best conduit you can use. And we thought that the gap between the two pouches should decrease with time, and this will make the anastomosis possible with time. Some surgeons will prefer to use elongation techniques. This elongation can be external, like the technique of Fokker or internal traction. I will show you a very interesting video of internal traction that is used by our friend Dariusz Padowski from Poland. So he will perform a thoracoscopy and he will free the two pouches. The video is not working, sorry. So he will free these two pouches. He will perform elongation of these two pouches. He will try to make them come close with non-resorbable sutures. And 1 month after, he will perform another thoracoscopy. And here you will notice that the two pouches are so close, and he will perform his anastomosis. And now he is performing his technique even without doing any gastrostomy before, because he's operating his patient at the age of 1 day, and he will do the second surgery only 7 days after. So this is very interesting because he's not performing any gastrostomy. So only one thoracoscopy followed by a second thoracoscopy only 1 week after. Just I will speak about the technique that we are using in Monastir, Tunisia. We try also to preserve the native esophagus. You see at the example, this example, the gap between the two pouches. And we begin by thoracotomy. We see here the two pouches that are very far from each other. So we are performing a cervical incision beside the thoracotomy. This cervical incision will allow us to gain a few centimeters that are very precious to make our anastomosis. And as you see, this upper pouch is very well vascularized. Don't be afraid to dissect as much as possible. This upper pouch is really very well vascularized, and this will allow you to make your anastomosis. So here we arrive to our conclusion. Esophageal atresia is the most common esophageal malformation. Now we are observing better results thanks to the cooperation between the anesthesiologist, neonatologist, and the pediatric surgeon. And here, this is a key point. The relationship, especially between the NICU and the pediatric surgery, is very important to have better results. And now, the aim of the management of esophageal atresia is not only to have a survival, but to have a good quality of life. And this is very important. Thank you very much for your attention. I will be happy to continue the discussion by email. This is my email. Also, I would like to share with you a few events that will come with the PAFIS, with our association of pediatric surgery, or our association of neonatal medical care, or also the IPEG Middle East chapter. Actually, I'm in the board of all this association, and this is really my honor. And if I can help our Libyan colleagues by this, I will be very happy. I also wish to invite you all to visit us in our department. We are here in the 6th floor in the pediatric surgery department, Fatuma Bourguiba University Hospital. We are very big team with almost 12 senior surgeon and 8 residents. We have also our medical school, our Monastir Medical School, in which we have a simulation center. The simulation center can be very helpful to perform surgery. And I hope also that you will make us very happy by coming and visiting Tunisia. Tunisia, you know, is a very beautiful country, and I think that we have a very nice relationship with our Libyan brothers. I think also that Libyan doctors are very smart. This is really honest. I think that Libyan doctors are very smart. This is what I noticed. And the best thing you must do is to have hope and to trust yourself. And I'm really sure that the future is yours. Thank you very much for your attention.
شكرا دكتور أمين على المحاضرة القيمة. الشباب في أي سؤال للدكتور أمين؟ تطرح أي سؤال للدكتور أمين؟
لو عايز أنت دكتور فريد make your videos perhaps and we will do a discussion after the videos.
أوكي تمام نبدأ إن شاء الله.
الوقت الأسئلة حتيجي بعدين إن شاء الله.
ما مرات يهرب الكهرباء مشكلتنا. اوكي تو الدكتور امين تحدث على كل النقاط اللي انا ممكن ولهذا بنبدا من اول واحده اللي هي جو اللي هنا جو سؤال تبان هذه. ايوه ولهذا في preferred technique which updated all around the world. I think many of us still with the open thoracotomy procedure. Some centers in Libya we don't use thoracoscopy repair. Also abroad nobody is using the slide tracheoplasty. There's increase endoscopic cauterization of the tract, especially in the recurrent tracheosophageal fistula. We will see this job of the ENT. I don't know if in Tunisia is available and you are doing something or no. And then with the experience of the surgeons, depend on which technique you want to use, okay? This is a video of an extraplural approach for tracheosophageal fistula from Professor Hendon, one of the famous pediatric surgeons around the world. Okay, I will just speak about little thing which
these items are inexpensive and always available. More recently, a similar tube has been made available commercially.
This is an tube that he inserted in the upper pouch. Okay, it's connected to a small tube inside it, which is this is closed in the upper pouch, and then there is a small tube inserted in this one. Why? Because the saliva with time becomes a little bit thick. So every time, sometimes the nurses and the neonatal they can irrigate it and then from the big and then aspirate it without damaging the mucosa of the upper pouch. Okay, this is one point.
It is in preparation. On the left,
if you do a good suction, continuous low pressure suction of the upper pouch with this technique.
مانيش نشوفه في الفيديو انت.
نعم
دكتور فريد مانيش نشوفه في الفيديو.
ما في اوكي ما بياخذ وقت تبغى نخليكم اوكي.
لا ما نشوفه بالمره الفيديو.
تمام.
With some suction on the upper pouch and gastrostomy venting of the stomach for 4 days, there was considerable clearing seen on the right. Definitive surgery was then performed.
دكتور فريد الفيديو مش واضح عندنا. حاول تشير سكرين مرة ثانية من فضلك. الفيديو مش واضح عندنا.
أيوة.
قاعد سلايد على البرزنتيشن.
لا أنا عندي الفيديو مش سلايد. أنا مطلع كله هذا سلايد.
أيوة.
إيه هذا طالع عندنا لكن الفيديو لا.
أيوة هذا الفيديو الحين.
يشبهوا فيهم يا روح ممكن.
لا. Some suction tube which we devised in 1959. It is a length of IV tubing with several holes into which is threaded a cut-down catheter.
دكتور فريد لا ما
These
نشوف.
items are inexpensive, always available.
يبان توا تسمع فيه.
دكتور فريد حط شو اسمه الديابوراما يعني الفول سكرين للبرزنتيشن بتاعتك.
هذا فول سكرين.
لا ما هي فول سكرين.
هيك نوت فول سكرين هيك.
هي حطها فول سكرين، حطها فول سكرين انت.
ما انت مش دقيقه بس نعودها من جديد كندا. ها ندير شير سكرين. صح كلامكم. هيك طلع.
انزل مره اخرى ترى انزل اللي بعدها.
دقيقه بس لا انا عرفت شو في مشكله هنا. المفروض ينزل لي هنا الواحد. كيف درت شير يور سكرين. درت شير يور سكرين. دقيقه بس. ده شيرنج سكرين. هيك ما تشبه شيء هيك ولا تشبه في حاجه.
ابيض هنا نحسه في سلايد بيضاء فقط.
دقيقه بس داير شير سكرين انا. هيك تو ممكن هيك المفروض شير سكرين ده. اوكي هيك.
اوكي
هذا البدايه برزنتيشن واحد من هنا.
خلاص شغاله.
Hence the holes in the outer tube. The smaller tube is irrigated frequently with saline to flush the system.
It's an old video, but it's very important.
From another child show the value of preoperative preparation. On the left is the admission film at age 2 days with severe right-sided pneumonia. With some suction on the upper pouch and gastrostomy venting of the stomach for 4 days, there was considerable clearing seen on the right. Definitive surgery was then performed. The infant is intubated awake and anesthetized with fluid banking. In some, only oxygen and curare are used. The umbilical cord is amputated. A plastic drape keeps the baby warm and dry and holds the towels in place easily, but we like to cut a window in it through which to operate. First, a stem gastrostomy is performed through a short rectus sling incision. Our approach to an infant, the baby, for a large baby in thoracotomy, as in this case. If there's a lot of pneumonia, thoracotomy may be deferred. Weak premature baby, we occasionally just divide the TE fistula extrapleurally. Then we can feed the child through the gastrostomy tube while maintaining some suction on the upper pouch and perform the definitive repair several weeks later. Note the gastric distension with air blown down. The child is then positioned for a right thoracotomy. In this baby, there was no pneumonia, and so an immediate repair is being undertaken following gastrostomy. Opening the chest with cautery makes blood loss negligible. With the refined pediatric anesthesia, which we have nowadays, it is safest to do these procedures with endotracheal intubation using a soft plastic tube. Anesthesia may vary from general to local or only muscle relaxants, depending on the size and condition of the baby. The intercostal muscles of the fourth interspace are divided, taking care not to enter the pleura. Using small retractors, the fourth and fifth ribs are elevated, which facilitates teasing away the pleura by blunt dissection. In the 1940s, most of the early cases of esophageal atresia were done through an extraplural approach, resecting several ribs posteriorly. Later, most cases were done transpleurally. Recently, there has been a return to the extraplural method because it affords definite protection in the event of an anastomotic leak. As will be shown here, rib resection is not needed to provide extrapleural exposure. The most tedious part of dissecting the pleura from the chest wall is the posterior gutter. It is easier to do this from the opposite side of the table, gently wiping the pleura from the chest wall with a sponge dissector. Here is the phrenic nerve, the azygous vein, and the innominate artery. The azygous vein is divided and ligated to give access to the esophagus. If a small hole is made in the pleura, it is best to clamp and ligate it, for suturing the thin pleura often tears it further. Here is the distal esophageal segment, little less evident than usual because this baby has a right descending thoracic aorta, which is pulsating in the foreground. Brief applications of cautery with a fine hemostat facilitate this dissection. The TE fistula, around which a ligature is passed. The fistula is then dissected up to the tracheal wall. With a ligature retracting the innominate artery forward, the upper pouch is identified when the anesthesiologist pushes down on the suction tube. A traction suture is placed in its tip, and it is dissected sharply away from the adjacent trachea, to which it is. In dissecting the upper pouch, it is easy to enter the trachea, which should be avoided. A proximal fistula should be suspected if the upper pouch is extremely small or if it seems to inflate synchronously with ventilation of the patient. The upper pouch can be mobilized far up into the neck without loss of blood supply. The thin-walled lower pouch, however, has a very tenuous blood supply, and we try to avoid mobilizing it any more than absolutely necessary. Here, gentle traction shows that the two ends will meet without tension. The TE fistula is ligated flush with the trachea. This is important in order not to leave a stump which can form a diverticulum. Formerly, we sutured shut the tracheal end when dividing a TE fistula. Simple ligation has proven equally effective, however, and it is probably safer if the child should require positive pressure ventilatory assistance postoperatively. If too great a gap exists, we do not attempt anastomosis because disruption from tension is often fatal. We would divide the fistula, close the distal segment, and pack it up to the chest wall to prevent retraction. The upper pouch can be marsupialized with the plan for colon-esophageal replacement at about age 1 year, or it can be stretched by prolonged bouchonage for attempted anastomosis in several weeks. Although it can be performed by several different techniques, we prefer a one-layer anastomosis with 6/0 Tevdek sutures, with most of the knots on the inside. Notice that there is very little handling of the esophageal ends with forceps, which can cause trauma. Instead, the forceps are spread within the lumen to expose the edge for suturing. We leave the tube in the chest for 7 to 10 days, much longer than in most thoracotomies, so that if a leak occurs, it will be evacuated. Usually, a leak forms a sinus tract, closes slowly, but anastomotic stenosis often results. When the back row of sutures are all placed, the assistant pulls together the ends of the esophagus so that the sutures can be tied without tension. If one does mobilize somewhat, the lower maintained, because an ischemic lower esophagus will slough and leak. In completing the anastomosis, as each new suture is placed, the previous one is cut. Note that the sutures are tied just tightly enough to approximate these delicate tissues. Some surgeons prefer an overlapping 2-layer anastomosis, as used by Dr. Cameron Haight, who first reported successful primary repair of esophageal atresia in 1941. The wall of the distal segment is so thin in these babies, however, that we prefer a single layer with not too many sutures to avoid ischemia of the lower segment. Some of the disparity in size of the two ends can be overcome by incising for a few millimeters the anterior wall of the lower segment. For most of the anastomosis, the knots are on the inside of the lumen. However, the last several sutures will have the knots on the outside, and they are not tied until all of them are in place. This affords greater accuracy in placing the last few sutures. It is not necessary to use a stent tube during or after an accurately performed anastomosis. As an additional safeguard against anastomotic tension, several sutures can be placed to gently tug the upper and lower segments toward the anastomosis. Although it takes a few extra minutes to perform an extrapleural procedure, there are two great advantages that it offers. First, the lung remains better inflated intraoperatively, and so it is less prone to pulmonary problems post-operatively. Secondly, should the anastomosis leak, a retropleural collection is more easily drained than a generalized empyema. Recurrent tracheosophageal fistula is another complication which can occur following anastomotic leakage. Note how the intact pleura has prevented collapse of the lung in this case. Known into the posterior gutter, about 2 centimeters away from the anastomosis. It should remain for about a week to 10 days in case a leak should occur, which can be evacuated by the tube. The chest wall is closed with chromic catgut. Day or two. The reservoir should be at a low level so that milk can back up into it rather than up into the esophagus. Here is a sine barium swallow taken 1 week postoperatively. There is minimal narrowing at the anastomotic site. There is some dyskinesia. There is
الو
ايوه دكتور فريد،
امين
نسمع فيك دكتور فريد.
وين اوقف هذا؟
ما بعرف.
اوكي هذا على الواحد بهي في حاجتين بس اوريهم لكم بعدين.
in this case, which occurs in about 5% of these babies with esophageal atresia. Shows that all is well operatively. The esophagoscope must be handled with extreme gentleness in so small anastomotic site that many of the sutures are still present. There is pericardium healing and very little narrowing is evident. We are using a 3 millimeter Storz fiber optic esophagoscope with a telescope which gently until one seems slightly snug. Even by this technique, it is possible to disrupt anastomosis by dilating into the forcefully and causing the wall to split. Multiple dilatations are anticipated. The gastrostomy tube is kept in place for an appropriate length of time to permit repeated dilatations by this technique. If an anastomotic leak has occurred, resulting in severe stenosis, it may be necessary to reoperate later. One can resect the stenotic segment down into the duodenum.
في حاجتين بس حنوريهم ثم باقي كل لحظة. وين هذا الواحد شير سكرين؟ أوريكم حاجة ثانية بس بالنسبة في اللونج جاب measurement, as Dr. Amin said, it's not taken anymore. Somebody go ahead the technique how we measure the gap, okay? تبان هيك تشبه فيها
gaseous abdomen at birth confirmed diagnosis of esophageal atresia without distal fistula. Untitled and gastrostomy tubes are removed. Next, a mercury-filled bougie is introduced into the oropharynx and under fluoroscopic guidance is directed into the proximal esophageal pouch.
الو
حطها فول سكرين، ما هي فول سكرين، ما نراه في الفيديو.
هذا فول سكرين.
لا يا دكتور فريد.
نعم فول سكرين حطيت. لحظة بس. هذا الشير سكرين لا؟ صحيح. لحظة بس. خير ما خشتش هنا المفروض. أنا نبغى تخش هنا. تخشني هنا. شير سكرين. هذه شير. غريبة ما خشتش. دير في شير سكرين وما تبيش يطلع لي هنا، المفروض تطلع لي. تمام دقيقة نشوف هذه. طلعت شكي هلا؟
لسه دكتور فريد.
تطلع هيك طلع ولا لا؟
لسه.
غريبة هذا كيف؟ بكريك كان يشتغل. لحظة بس ممكن طلعت مرة واحدة نعمل واحد زوم قاعد في الزوم. هرب مني الزوم مرة واحدة أنا. تمام.
لسه موجود، أنت لسه موجود.
إيه بندير شير سكرين هنا بنحط الواحد أنا بتاعي هنا المفروض، لكن ما نقدرش نحطها مين ننزل هذا شوية. تمام. غريبة. هيك ما شير. أيوه هيك حيطلع إن شاء الله.
إن شاء الله. خلاص هي حطها توا. حطها كلها يعني ديابوراما. لا حطها الكل دكتور.
هيك تبان ولا؟
اي تبان بس لازم
كلها.
الفيديو ما يشتغل الا ما تحطها الكل.
بس حتى مازال في هلبة فيديو.
دكتور فريد مرة والفيديو. دكتور فريد
نمشي قدام شوية.
ما نشوف الفيديو دكتور فريد، لازم تحطها فول سكرين وبعدين تشتغل راهو.
نعم.
ما هي فول سكرين دكتور فريد، ما هي فول سكرين. It's not full screen دكتور فريد.
هيك مش فول سكرين.
It's not full screen so we cannot see it.
أنا فول سكرين هيك شو.
It's not full screen. Put it full screen.
هيك تشبه فيها هذه الصغيرة.
ما بعرف أنا ما بشوف.
لا دكتور فريد مش واضح.
هذا فول سكرين.
دكتور فريد تقدر for the sake of time دير لنا شير للفيديوهات في الفيسبوك جروب واحنا نكمل ديسكشن توا.
رياسوم شير. ما تبانش عندك يا أروى؟
لا مش باينة عندنا دكتور. لو تقدر تديرنا ابلود للفيديوهات في الجروب تاع الفيسبوك وكل واحد بعد ما يشوفهم بروحه وتو نكملوا ديسكشن افضل.
لا
عشان الوقت بس
نشوفش على الواحد ما نقدرش ننزل مع فهمتي. الوقت اللي بيقعد فهمتي هيك يبان هو حاجه.
لا دكتور
هيك يبان حاجه يعني.
لا دكتور فريد
ما بان شيء هيك.
هي بانت بس الفيديو لا مش شغاله.
ممكن انتم المشكله يا دكتور. ها ايه شغال. هيك شغال. لا شغال هيك
صوت بس دكتور.
هيك شغال. بتبان الصورة.
لا دكتور الصورة ما تتحركش في الفيديو، صوت بس.
هني كاتبين لي هني إن sharing is paused. Bring your shared window to the front. شو معناتها؟
يعني لو أنت تقدر يعني تحطها فول سكرين دكتور فريد، يعني في ما هي فول سكرين دكتور فريد، سامحني دكتور فريد سامحني.
هيك توا
ايوه عليك نور.
خلينا نمشي شويه قدام بس بوريكم التكنيك.
ايوه نشوفها، قاعدين نشوفها. شغاله دكتور فريد شغاله.
يبان هيك توا
كويسه.
تمام.
Bronchoscopy at that time did not reveal a proximal fistula. She returns to the operating room for measurement of the esophageal gap to plan her esophageal reconstruction. The patient is placed under general anesthesia, and the replogal and gastrostomy tubes are removed. Next, a mercury-filled bougie is introduced into the oropharynx, and under fluoroscopic guidance is directed into the proximal esophageal pouch. The gastrostomy is sequentially dilated with 7 and 8 millimeter Hagar dilators. Traditionally, the esophageal gap is measured under fluoroscopic dilator inserted via the gastrostomy. With the Hagar dilator inserted distally, the gap segment appears to be 2 vertebral bodies length. A pitfall associated with this technique, however, is that blind insertion of the rigid dilator can miss the distal esophageal pouch and inadvertently distend the cardia, leading to a false and narrow measurement of gap. We propose substituting a pediatric endoscope for the Hagar dilator, thereby allowing the distal esophageal pouch to be intubated underdirected. The endoscope is introduced into the gastrostoma, and the stomach is insufflated. Channel is identified by the presence of bilious reflux. Upon withdrawing the scope, the incisura angularis between the pylorus and the gastroesophageal junction is identified. The endoscope is then carefully maneuvered into the distal esophageal pouch. With the endoscope in place, the esophageal gap can segment between 4 and 5 vertebral bodies. Critical for operative planning. Patients with narrow gap esophageal atresia may be amenable to primary repair with esophageal anastomosis. In contrast, long gap segments may require multi-stage repair with esophageal replacement. Because the gap length in this patient precludes primary repair, we will plan to bring her back to the operating room in 2 to 3 months to allow for further growth of the proximal and distal pouches. At that time, we will measure the length of gap in similar fashion prior to decisive operative planning. If the gap at that point in time is greater than 3 to 4 vertebral bodies, she will require an esophageal conduit.
اوكي هذا في واحد ثاني اللي هو هنشرحه بس على التراكوسكوبي مانجمنت بروكسيمال وديستال. هذه مست بروكسيمال ولهذا هذا ريبير. اوكي
So we did a pause and stop. So okay, keep going. We did right after each type and the orgasmic.
This through thoracoscopy video.
Hello, Matthias. Single. Can you hear me out? We ligated the distal fistula, and right after ligating it, we were still struggling with tidal volumes. So then we repeated the bronchoscopy, and then you can see it on the right side of the screen that there's a small pit describing the proximal tracheal
This is a long gap.
It's 6 minutes. So yeah, so I mean, I think the double speed. Yeah, that would be good. I mean, the important thing here. So, and I'm sorry, if the I could show you the X-ray, but just by X-ray, and it's so
how we can
again,
getting
to Dr. Ford's point, perhaps if I put a gastroscope in, as opposed to just contrast, we'd have a better idea. But I want you to just see how far up into the thoracic inlet you can get. You can see I'm dissecting all the way. I'm up by beyond near the tip of the lower lobe of the thyroid, if not higher. So we're well up into the thoracic inlet. And this is one of the advantages of a thoracoscopic approach, I think, is that you can see so much higher. Now here's the distal pouch. And this gap on contrast study with a repoval tube in the upper pouch and contrast in the lower pouch was 5.5 vertebral bodies. And so, again, it just mobilized all the way down down to the high.
Okay, so also you can try doing the primary repair also with gap measurement. Doctor أمين على tracheosophageal fistula technique اللي هو يبقى عليها بتاع
You missed because routine contrast studies may not show the recurrent fistula. Next slide. The definitive diagnosis must be made before a surgical attempt at repair is done because the operation is complex and can result in serious complications. The steps in making the diagnosis are as follows: an initial contrast study of the esophagus with the patient prone and a nasogastric tube placed into the stomach. The tube is then very slowly pulled back and contrast is injected. Next one. If this does not demonstrate the fistula, then a rigid or flexible bronchoscopy is carried out and an attempt to intubate the fistula is made. If this is unsuccessful, then dilute methylene blue is injected into the old pit of the initial TEF division with a gastroscope placed in the esophagus. And one little thing to keep in mind, a very simple thing, but people forget, always put your gastroscope into the esophagus before you inject the methylene blue. And always dilute the methylene blue 1 to 10. Otherwise, if you put straight methylene blue in, everything turns blue and you have no idea what's going on. And then once you get everything in place, you can inject the dilute methylene blue. Here's an example. Can you go back in that last one? Here's a very pretty picture of methylene blue, and it's not a huge gush coming through a fistula. On my right, you're seeing the esophagoscopy with the blue coming in. On the left, you see the contrast study showing a recurrent fistula. Go ahead, next one. Here's the pit of a recurrent fistula, as you see there. Here's another recurrent fistula. I'm going to run through these quickly. I don't want to spend a lot of time. Now, the other trick that I've found in finding it, it's not so easy to find the recurrent fistula. You'd think you'd find it easily once you open the chest. In fact, it's not so easy. In the early years, what I was doing was putting a little Fogarty catheter through the fistula into the esophagus, blowing up the balloon and leaving it there. The only trouble is sometimes the ear deflates without you realizing it, or sometimes the balloon breaks as you're starting to mobilize, and then you can't really feel the catheter. So what I've done in the last several years is put a glide wire through a bronchoscope into the fistula and into the esophagus, and then put a gastroscope in before we start the case, and grab that glide wire, bring that out of the mouth along with the other end out of the mouth, put a hemostat on it, and have the anesthesiologist hold that. Then open the chest and start to dissect to find out where that fistula is. And the way you can go for it real quickly is have the anesthesiologist pull back and forth on it, and you're going to see it sort of like a saddle on a horse. It's going to move up and down, and that's where the money is, and that's where you want to go to dissect out the fistula. Next.
Okay. This is the job done by the ENT colleague who are expert with bronchoscopy and the treatment of cauterizations of the fistula tracts.
Tracheosophageal fistulas. And there's a lot of different tools and techniques and angles telescopes that can be of assistance. What you're seeing in this video is that we're using an angled telescope to visualize a very small tracheoesophageal fistula in the upper trachea or virtually just below the subglottis level. And just that little black dot is in fact a tracheoesophageal fistula being visualized with a 70-degree angled telescope. Here we've got another quite useful example of a child who's had a TEF repaired, and we're probing it. And we know that this child's still aspirating because they've had an esophagram. We've seen contrast go into the esophagus, into the trachea from the esophagus, and we're probing the TEF repair, and that's a good TEF repair. And so you start looking. And again, these things can be surprisingly hard to find. The second congenital H-type TEF, and there it is. And you can see it's not small, but it was not an easy thing to find. And so that's just replaying that same little segment. You can see distally, you've got a great closure, and you know the child's aspirating, so you go in with an index of suspicion. You want to look for the second TEF. And as you know, this is using a Bugbee cautery as a probe. There's a groove which makes you suspicious. You want to probe that little divot, that little groove, and in it goes. Suddenly you see the fistula. Similarly, here's a girl who's had a tracheoesophageal fistula closed, and we're going to probe from the back to the front. So this girl's got an inadequate posterior cricoid. You can see she's trach dependent. You see an area that looks awfully suspicious at the apex of her past type 3 laryngeal cleft repair. So how are you going to establish whether that is in fact a fistula or if it's just a divot? So this is using a probe showing she's got no posterior cricoid. Everything's very soft. This is using an alligator, and the alligator, as you open it, goes straight through the hole. So you know she's got a fistula, and this is the post-operative result after we placed a posterior graft and decannulated her. No fistula, adequate posterior glottis, quick look down the esophagus. And this is again a similar view with an endotracheal tube in the esophagus. And what we can do here is if you put a slightly, a little air in a cuff of an endotracheal tube, and you then look down the esophagus, and the tip of the tube is proximal to the tracheoesophageal fistula, and you give a positive pressure breath, you should be able to see if there's any bubbling coming out of the hole. So now we're looking at the tracheoesophageal fistula, or what we're suspicious is a tracheoesophageal fistula. We're giving a positive pressure breath. You'll obviously have to vent the G tube or stick a nasogastric tube in the stomach afterwards, and you can clearly see bubbles coming out through that hole. So that confirms it's a tracheoesophageal fistula. This is, again, a combination flexible bronchoscopy, esophagogastroduodenoscopy, where you can literally see one telescope looking at the other telescope through a subsegmental bronchus. Now, if you see that, there is no doubt that you've got a hole. And this is just a fun little video that one of our fellows made a year ago. I quite like the Star Wars effect myself. And this is where you've got the EGD admiring the light of the flexible endoscope. And hello. That's not normal. Hello. Which is a 2 French insulated wire with a line, urologists generally speaking. That's removing the suture. You can see the esophageal mucosa there. We're now going to demucosalize the tract with a Bugbee electrocautery, which is a 2 French insulated wire with a live tip. And Once we've demucosalized the tract, we're then going to put a tiny bit of fibrin glue just to try and plug the hole temporarily. And then we'll see the results a little bit later. So here's the bug bee. And this is just demucosalizing the tract. In the interest of time, I'm going to move forward to the next slide before the tissule goes in there. Same child 6 months later. And it is the same child.
Can I ask what the biggest fistula you guys have been able to close endoscopically is?
Probably that one, actually. It was a decent sized hole. And so
okay, this is a new trend, especially for the recurrent tracheosophageal fistula. It's a usual surgical procedure for tracheosophageal fistula. Recurrent, as Dr. Amin said, needs a sharp surgical procedure and with in fibrotic area with risk of bleeding.
So there's normal vocal cords. Anesthesia is not the time to check for vocal cord function. There's normal subglottis, T1, T2, and T3. We'll talk about what that means. Right upper lobe, bronchus intermedius, right main stem. There's the left main stem. And it's important to realize when you're doing these, there's a typical or common L2 or mid left main stem posterior intrusion from the descending aorta in children. And when they cough, you can see that posterior membrane goes and intrudes into the lumen a little bit, less than 50%. So that's a very normal trachea. Less normal, but not uncommon, is a child with isolated tracheomalacia, no prior surgery, just born with a progressive cough and respiratory infections, like we said above. And there you can see that the airway has some secretions in it. There's a posterior intrusion, the posterior membrane's intruding into the lumen. You have anterior collapse, mostly from the right, distorting the trachea more to the left side.
Okay.
The trachea is T1, T2, T3, carina, and this is our classification system. The reason for the regional system is so we can talk on the phone, we know exactly what we're talking about. The middle diagram demonstrates a normal C-shaped cartilage on the top. I would advocate that the U-shaped and bow-shaped cartilages, the two on the bottom, are actually congenital malformations of the trachea. Because the cartilages almost always aren't floppy. They're not molasic, as people are taught. They're totally fine. Structurally, they're just mal-shaped. And then the third shows that you have posterior intrusion, which is typically dynamic, and anterior collapse, which is typically a stenosis and caused by vascular compression. And this just shows you posterior intrusion in an otherwise normal airway. You can see the cartilage is sort of U-shaped, and the posterior membrane just intrudes into the lumen. This is segment T2 here, for those who are precise. Go. And this is the static picture demonstrating a big saddle at the innominate artery in T2 caused by vascular compression. But when you take that vessel off, the cartilage doesn't change shape. It just stays there. So what are some of your options for airway collapse? Some of these you may not have heard about. Anterior aortopexy. Dr. Filler introduced that in Canada in the 70s. A posterior aortopexy. Few people know about that. Pulmonary artery anteriorpexy. Those of you who approach the aortopexy through the left chest probably inadvertently do pulmonary artery pexies because that's the first big blood vessel you see. Anterior tracheobronchopexy, going directly onto the trachea and pulling it forward. A posterior tracheobronchopexy, which we'll talk a little bit about. Airway stents, external airway splints, tracheostomies, tracheal resections, or all the above. All the above. All the above, exactly. Now, some of these are posterior bronchopexy. The concept behind a posterior and anterior tracheopexy are pretty simple. You have an airway that's having dynamic or static compression, you just want to fix it. The problem for the posterior membrane is that there's an esophagus and a thoracic duct in the way. But frankly, we're surgeons, so we can move those. Just get under the thoracic duct, it's a safe plane, and push it off into the left chest. And the esophagus can be easily moved into the right chest. And then you have a wide open access to the anterior longitudinal ligament of the spine. You then take that posterior membrane and attach it to the anterior longitudinal ligament of the spine under bronchoscopic visualization so you can optimize the position of the suture so you open up the airway. And in fact, this can go all the way out to L3, which is the distal left mason, and all the way out to the bronchus intermedius in the right upper lobe in kids who have severe bronchomalacia. The trachea, normal.
Okay, I think it's enough because في الجاسك ترانسبوزيشن هذه التكنيك بتاع لويس.
Starting, we've opened the abdomen through a left subcostal incision. We've freed up the lowest segment of esophagus there. We remove that with a stapler. Take it down the left gastroepiploics. I do a pyloromyotomy, not a pyloroplasty. I know Lewis likes a pyloroplasty better. I'm not sure. It's simpler to do, and that's why I do it. I then go up into the neck, free up the cervical esophagostomy. And then this is the part I hate to do because it always scares me. I do a blunt mediastinal dissection. I've not had a bad bleed in doing that, but I always worry it's going to happen. And then what I do is then pass a 32 French polyvinyl chloride chest tube through that tunnel and use it to grab the stomach, which you see we've done here. We bring that stomach up into the neck. I anchor it to the sternocleidomastoid muscle laterally and to the strap muscles medially so it can't fall back into the mediastinum. And then I do a single layer anastomosis of the esophagus.
Okay. The colon substitute like it takes long time. It's enough, I think. هذا esophageal atresia بالنسبة لفوق تكنيك اللي هو الستاندر تكنيك. Okay. I think it's enough now. ايوه دكتور امين.
بارك الله فيك دكتور فريد.
عفوا انا اعطيت حاجات لكن كانت شويه صعب معناتها على الاقل يشبه الشباب يفهموا شنو الحاجات اللي ممكن تندار في
بارك الله فيك دكتور فريد. Just كان بعد اذنك we will pass to some questions. في question الاولى من دكتور احمد سعيد. Which case then be extubated safely post anastomosis. أنا زي ما قلت لك I think دكتور سعيد that we must keep this patient intubated for 2 to 3 days because the main concern is when we will need to reintubate very soon this patient, and here it will compromise the sutures. So I think this is a rule. We must keep this patient intubated for 2 to 3 days and after try to extubate this patient if you think that the patients are okay. يعني لو لا قدر الله في signs of mediastinitis, keep the patient intubated. This would be better. This is what I can tell you. The second questions is.
أنا أعرف something دكتور.
تفضل دكتور فريد.
أيوة. بالنسبة to keep a baby intubated depends on an intraoperative. How is your anastomosis? Is it under tension? Okay, so some advice also to put them, paralyze them post-operative. Okay, so they can't move and doesn't disrupt the anastomosis. The trend up to date is to try to bring the هرب لتريك. تسمع فيها لا؟
اسمع فيك.
هرب للكهرباء يشعل المولد بعد شوي. ولهذا الترند today is all of them trying to do, as we spoke, primary repair. What does it mean? It means to go ahead and to bring the two, the upper and the lower pouch together. Why? Because as Dr. Amin said, with the new technique and what we saw, that the upper pouch, we can go ahead and dissect it as much as we want, and we can get length. And about the lower pouch, about few years back, they advised not to dissect a lot So we don't want to damage the vascularization. But nowadays they dissect it because we know later maybe they will need fundiplication, depends on the situation of the baby later on. Okay, هذا اللي نقدر نزيد من نقطتين بس.
شكرا دكتور فريد. For the second question, in your opinion, which one you prefer, to do esophagostomy or keep on section? يعني دكتور أحمد هنا بيحكي على الكيس of long gap esophageal atresia. What will be the best option? أنا من رأيي اللي we will keep under section. ليش؟ لأنه if you perform esophagostomy, perhaps you will lose few centimeters when you will perform your final anastomosis. احنا زي ما قلت لك مثلا في المونستير بنفضل نخلي native esophagus. Native esophagus is always superior than when you use substitute يعني colon ولا stomach ولا حتى small intestine. يعني احسن شيء لما تخلي native esophagus. زي ما شفت في البرزنتيشن what we are performing in Tunisia في القسم بتاعنا احنا بنسوي cervical incision, and the cervical incision can give us few precious centimeters and perform our anastomosis. عشان كده بنخلي البيشنت under section after we will perform our final procedure. في بس remark حبيت نقولها في رأيي الشخصي، في كمان تكنيك very interesting هي الانترنال تراكشن. هي حبيت اوريكم الفيديو بتاع داريوس بادوفسكي، هو جراح بولندي اللي بيسوي انترنال تراكشن. يعني المريض اللي عنده لونج جاب اوزوفاجيال اتريزيا بيسوي له توراكوسكوبي. بس اقدر اقول لك انت ممكن تسوي له حتى توراكوتومي لو ما عندكش البوسيبيليتي تو بيرفورم توراكوسكوبي، وبعدين يعمل انترنال تراكشن. يعني هو he will free the upper pouch, he will free the lower pouch، وبيعمل فقط one sutures to make these two pouches to come close، ويخليها كده. بعد اسبوع او اسبوعين فقط بيسوي توراكوسكوبي ثانيه او توراكوتومي ثانيه، انا اقدر اقول لك ممكن معناتها، وبعدين تتفاجئ اللي التو بوشز يقتربوا من بعض، وكده بيسوي الفاينل انستوموز. يعني it seems very attractive، جميله جدا كتكنيك. يعني الفيديو للاسف ما اشتغلت، بس اقدر ابعثها لك لو عايز بالايميل او تشير with you by Facebook او حاجه زي كده. يعني very interesting procedure for long gap esophageal atresia. ما بعرف دكتور فريد لو انت عايز تقول شيء.
ايه تفضل. كويس. المشكله الوحيده في الحاجات هذه الانترنال حتى advised by في اللونج سيجمنت ستريكشرز، اوكي، اللي هم they want their own esophagus native esophagus، اوكي. ولهذا الترند حتى فوق في الايرلي هيز تكنيك واحد he's speaking about the native esophagus is the best esophagus, okay. So he tried long segment, he don't resect anastomosis, he used the internal to gain length, and then he do his anastomosis under tension. This is the problem. Under tension means sometimes ischemia. Here is the point of view where problem, and so stricture is probably will, and the area to do two anastomosis after surgical operation or attach, there is fibrosis. You need to resect the fibrotic tissue because you want to gain a healing. So you need a good two proximal and distal anastomosis to have good healing.
اوكي ان شاء الله خير. فقط we will go to the other question من دكتور عبد الغني. How we know if the gap between upper and lower pouches is short or long pre-operatively, number of vertebrae to decide if it's suitable to perform primary anastomosis or not. Very interesting question دكتور عبد الغني. يعني دكتور عبد الغني عايز يحكي على اللونج جاب اوزوفاجيال اتريزيا. ازاي احنا نقدر we appreciate the distance between the two portions عشان نقول اللي هذه ممكن نسوي لها primary anastomosis وإلا لا. احنا الاسسمنت بتاع الجاب ازاي بنسويها عندنا؟ يعني في gastric tube in the upper pouch، واحنا في العاده يكون عندنا جاستروستومي ونعمل اوباسيفيكيشن من الجاستروستومي، يعني ويل انجكت برودكت في الجاستروستومي، وهنا تقدر تعمل ايفالويشن في الجاب بين ذا تو بوشز. هو كلامه صحيح، هو في ابحاث يقول لك لو الجاب between the two pouches is 2 to 3 vertebra يعني it's possible to make our anastomosis، يعني 2 vertebra is possible to make your anastomosis. لكن sometimes this is not very real. في العاده احنا بنستنى يعني ثلاث اشهر حاجه زي كده. We will perform our يعني assessment, radiologic assessment. وafter we will decide to perform the anastomosis. احنا في بعض الحالات حتى والله لقينا جاب بتاع 4 vertebra 5 vertebra، بس بالتكنيك اللي حكيتها لك بتاع cervical incision we can gain even 2 centimeters 3 centimeters and we can perform our anastomosis. يعني long gap esophageal atresia it's tricky، مش دايما الامور واضحه جدا معناتها. في العاده زي ما قلت لك معناتها الحين ولات الفتره حتى بتاع الانتظار قبل to perform the primary anastomosis عمال تصغر. يعني قبل كنا نستنى 4 أشهر 5 أشهر، الحين 3 أشهر. في بلدان أخرى يقول لك 4 weeks to 6 weeks to perform the final anastomosis. وزي ما حكيت لكم معناتها التكنيك هذا بتاع داريوس بادوفسكي يستنى أسبوع فقط to perform the final anastomosis.
We tried conservative without doing cervical esophagostomy just by putting upper pouch in continue low suction. The problem, how long, this is the timing, and how long you are going to leave them in the hospital or discharge them, and who will take care of them at home for the salivation. في واحدة من الحاجات كانوا مديرينها إن هم أنا ما أظن one of I don't know which place they take an NGT and they crawl it do multiple على الtongue and with stitches, okay, and open many holes so it helps for the salivation to come out, you know. في تكنيك وتريكس وحاجات معينة هذا لكن our problem is for the interposition. We have operated by a visitor came to us, I think from Austria or somewhere, yeah. He done for us 3 or 4 cases of pure esophageal atresia about 10 years back. They survived. واحدة منهم expired just. That's what can I. Okay. شنو الأسئلة الثانية؟
سؤال من كاتب زوم يوزر ما بعرف الاسم. What best diagnosis of H-type fistula with suspicion by history? This is also a very good question. I think that the standard, the best diagnosis tool is to perform bronchoscopy, and it must be done by someone who is experienced. يعني في ناس بتعمل upper GI study حقيقة في بعض الأحيان تكون الفستولة صغيرة ما يمر البرودكت ولا ما تكون واضحة، ولا في بعض الأحيان بيسوي يعني ريفلاكس وبتعتقد اللي هناك فستولة بس ما في فستولة. The best thing is to do the bronchoscopy to make the diagnosis, and also bronchoscopy would be very helpful in case of surgery. دكتور فريد لو عندك ما تضيف.
بالنسبة H-type fistula, as bronchoscopy can help, okay, in case you have a good ENT who can, pediatric ENT can help you to proceed with if he can put the technique which I showed previously by Quran, to put something from the fistula through the bronchoscopy and at the same time to bring it out with the gastroscopy and bring them together intraoperative during the procedure. So when you open, it depends the level. If it's high, you want to proceed from cervical, or you want to proceed from thoracotomy, then the anesthesia can help you bringing them. Putting Hager inside the upper pouch, then it's problematic. It close to you, and you don't see intraoperative the site of the fistula. An important thing, as what the video shows, is when you want to damage the esophagus. Don't touch the trachea, okay? So you can open in the esophagus and then you stitch it, you close. But the trachea, minimal tear in the trachea, it's problematic. So taking bites in the trachea will not heal, and you will be disturbed and post-operative problematic for the baby in the neonatal ICU. That's what I can say about it.
نمر للسؤال اللي بعد من دكتور أحمد فتاح. What is your protocol for dilation? Very nice question دكتور أحمد. أول شيء اللي حبيت نقوله لك اللي بعد الفولو أب احنا ما بنسوي upper GI study systematic. لو المريض symptomatic we will perform an upper GI study. After we will perform our dilation. All will depend on your constatation. If it's very stenotic, يعني very tight, here we will probably perform another dilation 2 weeks or 3 weeks after till we'll have a good result. هي في العاده اللي حسب الاكسبيرينس اللي عندنا في تونس، عشان احنا في تونس بنسوي كمان الدايليشن، عندنا دكتور منجي المكي ودكتور لسعد صحنون بيسووا هذه الاوزوفاجال دايليشن. يعني في العاده الاوزوفاجال اتريزيا يعني ستينوتيك فورم ريسبوند فيري ويل افتر دايليشن. وزي ما قلت لكم في المحاضره اهم شيء هي البريفنشن. اهم شيء البريفنشن نتاع ستينوز. البريفنشن تتسوى when you prevent the ischemia and you prevent the fistula. يعني لما انت تسوي السيرجري بتاعك لازمك تاخذ الميكوزا، هذا لازم يكون very important. لما انت تعمل الدايسكشن you try to dissect as much as possible the upper pouch and not the lower pouch to not compromise the vascularization. خاطر كان فما ischemia we will have stenosis. ولو انت سؤالك كمان تحكي على الكورتيكويد، يعني في ناس بتحط كورتيكويدز مع البالون when they make the dilatation. في كمان بروتوكولز اخر اظن ان هذا ما عنده efficiency، يعني في studies تعملوا and it's debated. هذا هو البروتوكول اللي بنستعملوه في المناسير. اتمنى نكون اللي اجبت على سؤالك. ما بعرف دكتور فريد لو عنده اضافات.
بالنسبة للبروبلم تاع dilatation, as you said before, how to prevent stricture. So the new trend is not anymore to put down until the trans-anastomotic tube. You can put it just to be sure that there is nothing down, stenosis, congenital or something like that. But leaving it and depends on the size. زي بالنسبة للhypospadias, they start with the size. When they finish, they change to smaller size. Okay, like in the trend nowadays, they are advising not putting because one of the causes for the stricture post-operative. The other thing, protocols about how long every 1 week to there's an old paper from Charlie, I think, from Switzerland. He's speaking about early prophylactic calibration, not dilatation. And the baby is alive. You just go in and out, prophylactic calibration, not dilatation. The third things during using the balloon dilatation, somebody advised using what they call metocene or something like this. Surrounded على البالون بتاع الديلاتيشن فقط اللي ده يعطي افكت لوكالي افكت على الاريا بتاع الفايبروتيك هذيك. How to do it for how long قداش مره معناتها نحتاجه ان احنا في ما نعرفش البروتوكول هذا gastroenterologist. I think it's a job of gastroenterologist in abroad. but in our countries, usually who has experience of pediatric surgeon, they are doing it. هذا بيكون under fluoroscope, under screen, and when to stop and where to go, how long you go inside the structural area, or how long you go. I think if you have experience, I don't have experience with it, sorry about that. That's my points about it. With prevention of ischemia during the anastomosis, how many stitches you are going to get. There are many things. واحدة من الحاجات هي interposition between the trachea and the esophagus site. They prefer not to put anything in the flaps, nothing, okay, because it's increase the fibrotic area, which one of the causes of the restrictions. That's all what I have.
شكرا دكتور فريد. الكويستشن التالية من دكتورة منى. Anytime intervention if recurrent case. لو فهمتك كويس انت تقصدي لو في recurrence of the tracheoesophageal fistula. على ما اظن هنا لازم نسوي re-intervention as soon as possible. بس في بعض الاحيان ايش المشكله اللي تنجم تصادفنا لو في عندنا recurrence of the tracheoesophageal fistula? We will have patient with a very bad statement. يعني حيكون عنده bronchopneumonia, حيكون عنده في بعض الأحيان white lungs in the X-ray. يعني لازمنا نحضرهم كويس عشان surgery. It's a big surgery. It's not very easy surgery. نحضرهم كويس عشان يتحسنوا في الحالة متاعتهم to perform the surgery. يعني في nutritional statement وكمان في infection statement. معناتها هذا very important to make the surgery successful. والحين اللي فما اللي حبيت اللي كنت عاوز اقوله اللي الحين في كثير من الاحيان بنسوي الاندوسكوبيك سيرجري is very efficient. يعني في مين بيسوي injection of glue والا of fibrotic agent. It can be efficient. والا كمان في كمان الكفر ستنتنج. يعني تحط ستنت في الاسوفاجوس cover stent, and this can protect to have the fistula. It can be final treatment وإلا bridge treatment. يعني ستنت يحسن لك المريض شوي وبعدين تسوي العملية في ظروف أحسن. هذا اللي عندي ما أقوله لك بالنسبة للريكورنت كيسز. لو فهمتك كويس دكتورة منى. سامحني دكتور فريد. تفضل.
بالنسبة للكونتراست بالنسبة للريكورنت tracheosophageal fistula, as usually every recurrent takes time to start manifestation. تبدا انت تقول ان في structure في something wrong, but as we know complication في early وفي late. Okay, so here's the decision making. If you go for a recurrent tracheosophageal fistula in general, you need intraoperative to be sharp because fibrotic area, okay, after you dissect and separate the area اللي فيها anastomosis disruptions or what else finding intraoperative, doing your anastomosis again you need a healthy tissue. هذه علاش بقول لك انها هي you need sometimes حتى under tension anastomosis. ولهذا post operative we need care. The baby from the natal ICU sometimes paralyzed him for a little bit. That's what I can add to it.
Okay, thank you. السؤال اللي بعد من دكتورة سارة أبو ريمة. Do you see still cases diagnosis with contrast study? سؤال وجيه دكتورة سارة. هو في الحقيقة ما عاد تشوف. No, we don't see this case. Really, contrast study I think should be forbidden for the esophageal atresia treatment. It's not useful and it can be harmful for the baby. بس أقول لك شيء فقط. في بعض الأحيان we can perform this contrast study في some cases. أقول لك مثلا في بعض الأحيان اللي you suspect a proximal tracheoesophageal fistula, we can do a very careful contrast study. بس هذه لو انت ما عندكش برونكوسكوبي وعندك very high suspicion you can perform it. بس زي ما قلت لك it's contraindicated, it's harmful for the patient, you should forget it for the diagnosis of esophageal atresia. Dr. Farid?
Also, if you want to do it, you don't use barrier. You can use diluted, and after you took your film directly, you aspirate it. Okay, because عندك هالفيروس انت go in trachea and then consequence of pneumonia and problematic respiratory distress. Okay, but usually we don't use it for usually for recurrent tracheosophageal. حتى 3-dimension bronchography CT scan give you a good view if you have it. I have done it 1 or 2 times in Tripoli, and it gave me a very nice picture as you are doing bronchoscopy. Okay, because our colleague ENT, they are not fit of doing the neonatal. I don't know now if they started. Setup is available. Okay, but who will do it? It's not available. This is the problem. Okay.
One other question now from Tunisia, from my friend Dr. Ben Saleh. Very interesting question. If initially the gap was judged sufficient and the newborn was operated, but unfortunately we discovered that the 2 pouches are not long enough to perform the anastomosis, what to do in this case? This is very interesting question. As I told you, sometimes even in type C or D esophageal atresia, you can find a situation that the primary anastomosis is impossible to perform. هنا situation هذه is very complicated عشان فيها the fear from not succeeding the surgery, وفيها زي ما تقول الغرور متاع الجراح انه هو ما نجح ولا ما سوى العملية. يعني في بعض الأحيان لازم الجراح يقول ما بقدر أسوي الأنستوموز. He should not يعني insist to make the anastomosis because this will be very harmful and you can lose your patient. أنا إيش أسوي لو أنا ما قدرت أسوي الأنستوموزس؟ يعني فقط I will ligate the tracheoesophageal fistula. يعني هذا هام جدا to ligate the tracheoesophageal fistula because يعني ما باش يكون عندنا مشاكل متاع air loss ومتاع gastroesophageal reflux in the bronchi وحاعمل يعني upper section وحاعمل المانجمنت زي ما يكون long gap esophageal atresia. يعني اقفل just lower pouch اقفله واخليه كده وبعدين اخذ وقتي عشان اسوي العمليه متاع اللونج جاب اسوفاجيال اتريزيا، يا اعمل برايمري انستوموزز والا اسوي اسوفاجيال ريبليسمنت. بس زي ما قلت لك دكتور بن صالح it's very interesting question because this is situation you can face. يعني في العاده صعب وفي بعض الاحيان الجراح يصر اللي هو يسوي العمليه بتاعته ويكملها وفي الاخير تكون فيها يعني مشاكل كبيره. والا زاد كمان معناتها الاذر سوليوشن you can do internal traction. يعني هذا it can be very interesting. يعني انت سكرت الفيستولا وبعدين ايش حتسوي؟ يعني حتسوي فقط سوتشر ما بين التو باوشز they will become close and you can after perform your final surgery after 2 weeks or 3 weeks and I think it would be possible to perform your anastomosis. دكتور فريد سامحني. دكتور فريد في عندك ما تضيف؟
Yeah, about the intraoperative finding of a gap which preoperative was not assessed well or planned to go directly and trying to do resect up the pouch until where they arrive gaining length and the lower pouch and then there is still a gap. Problem in all technique they are using circular myotomies. Nowadays we don't advise it because it will pay its future more extensive dysmotility over time of the esophagus. But if accidentally you couldn't do it, chose just to put, as you said, about 2 traction suitures and with sliding knot over the edges of the proximal disc, and hope may slowly approve 2 ends with time, making ممكن possible to do second stage closing. This is the internal. It's the external. It's a little bit problematic and needs more care. That's the only thing which I can say about finding. But this depends preoperative assessment. If you have a good setup and you can see all technique to put bouger up and down and do dilatation, maybe you gain more length, takes time, and depends on as we said previously, it's a spectrum. There is the vector and the charge associated anomaly, which must be taken in care. That's what only I can say about this problem about the gap. The gap, as we know all today, there's no more. What is the definition of gap? Okay, nobody can tell you what's the definition. Missing vertebrae, how many centimeters. This is just because you see from outside, not inside. Thoracoscopy, maybe as a diagnostic preoperative, if it's available to have just a look about the distance, may help maybe. And Rottenberg, he's speaking about that he can do whatever. We saw 5-6 centimeter of gap, and he brought them together as your technique in monastery. Maybe you are now, how many centimeters you gain when you go up and bring what you want. Depends on the experience of the surgeon. Okay, that's all. About doing the procedure في risk على البيبي. We spoke about extraplural approach. Maybe this will change when we want to do it intrapleural approach. Also, this is a good question. Okay, when we can change it, intraoperative and everything, and we couldn't bring. So there's a lot of things to be speak about. And the anesthesiologist has a big rule to stay and follow you, because he can tell you go ahead or stop, because maybe intraoperative it's easy, you can lose him for anything. Also about having the right incidental finding of right aortic arch during right thoracotomy. Preoperative echocardiogram didn't demonstrate it. What you are going to do, you want to change or you go ahead. Nowadays they continue from the same side, right side, just to take care, because the aorta there looks like esophagus. Maybe you pick it up and think it's an esophagus and you miss it. That's what can I tell. But about doing myotomies when there's no benefit to gain length by myotomies. Okay.
Another question, interesting question. What about speech prognosis? I think you are speaking about speech classification that was described in 1994, and that divide the esophageal atresia in 3 groups depending on the weight. Is it superior or less than 1.5 kilos, and in the presence or not of major cardiac anomalies? I think this is a good prognosis classification, but nowadays the major prognosis factor is the presence or not of major cardiac malformation. The weight is important, but it's not the biggest issue. The major thing is the cardiac anomalies.
The problem about water or no water, Pena says always, water or no water, it doesn't matter. Because about speaking about cardiac associated anomaly, when is the time to operate? Our colleague, pediatric cardiac surgery, they usually wait until 5-6 months of age to go ahead with their repair. So we will wait for them. Okay, so and the important thing in the examination, physical examination, when you visit a baby with esophageal atresia, to check the anus, because they have a high incidence of associated anorectal malformation. So also that there is a question now about the intestinal atresia. Also, if there is imperforated anus, what you are going to do? Okay, so we will follow. About, I think about the classification, as you said, weight and many things change because with the progression of the anesthesiologists and specialized pediatric anesthesiologists, they are helping us and they know how to deal with the baby. Because one of the things is also you spoke about no mask, oxygen mask. Also, the anesthesiologist must use a neonatal machine. Okay, but usually in the OT, there's the machine which is used for adults, for children older than neonatal period. It's problematic, many things. Usually they comes intubated from neonatal ICU to the central OT to be operated. So connecting them there in the neonatal ICU, they are on pediatric set of anesthesia. When they come OT, I don't know in your country the same thing, or you have also in the OT neonatal anesthesia machine.
Actually, we have, you know, there's a lot of prognosis related to anesthesia, and we have more and more qualified anesthesiologists that can deal with neonates, and we have more successful result due, yani, thanks to the anesthesiologist.
Because one of the things is during the intubation and starting if there is a large fistula, there is a risk of perforation of the esophagus or a pneumothorax. So is there a route to put a prophylactic chest tube to help them to arrange until you go, or to do decompressive gastrostomy, or to put something just deflate the stomach, the standard stomach, because it's pulling up the diaphragm, and babies and the anesthesiologists are afraid that something is wrong. So they need your help directly. As you said, you open thoracotomy and close the fistula, takes time, you know, and risk for the anesthesiologist. So there's many things to take in consideration, how to react urgently without losing the baby.
Yes, this is true. Okay. Now we will have another question, Dr. Farid. حاب أشكرها حقيقة دكتورة منى. هو question very interesting. In any case, tracheosophageal fistula with intestinal atresia, any one intervention surgically first, as your opinion? This is very nice and very interesting question, دكتورة منى. احنا زي ما شفنا في الليكتشر we can have duodenal atresia وإلا intestinal atresia وإلا anorectal malformation that are associated to tracheoesophageal fistula. في العادة decision will depend on the statement of the baby. يعني لو هو the statement is very poor وإلا هو حالته كويسة، يعني هذا will make our decision. في العادة دائما we will always try to begin by the tracheoesophageal fistula. يعني at least to close this tracheoesophageal fistula to have a better statement، يعني يقدر يتنفس أحسن، نقدر المانجمنت يكون أحسن بالنسبة للبيبي. لو هو الحالة متاعه كويسة، يعني في العادة أحاول أعمل الأوزوفاجيال أتريزيا واعمل انستوموزس، وكمان بعدين اسوي لاباروتومي تو بيرفورم يعني duodenal atresia والا الانتستينال اتريزيا. وان كيس اوف انوركتال مالفورميشن تقريبا في اغلب الحالات تكون هاي فورم، في العاده بنسوي كولوستومي، الا كانت واضحه جدا اللي هي فورم ذات از لو فورم، يعني حقيقه واضحه جدا انت هي لو فورم، وقتها نسوي انوبلاستي. بس في العاده بالنسبه للانوركتال مالفورميشن احاول دائما افضل اني دائما اسوي يعني كولوستومي. it's more safe، يعني more safe more quick to realize for the patient. هذا لو هو حالته كويسه. زي ما قلت لك لو حالته مش كويسه او اضعف الايمان احاول اقفل الفيستولا على الاقل، وبعدين اسوي يعني في مرحله مقبله اسوي الانستوموزس بتاعتي، وبعدين اسوي الديودينال اتريزيا يعني لو هو حالته تحسنت. هذا اللي اقدر اقوله لك بالنسبه للبلان if you have the association of tracheosophageal fistula and intestinal atresia or anorectal malformation.
بالنسبه للانوركتال مالفورميشن حسب فاهمين قلنا واحد انه هو سبيكترم. اوكي، لو انه هو perianal fistula ولا vestibular fistula where we have a fistula at that area, that time we start just doing dilatation and the rectal washout without, because doing two operations at the same time is critical. Okay, stabilize the baby, and if you want to close the fistula and there is this emergency saving life, also feeding gastrostomy or decompression gastrostomy is associated with it. So doing, if it's a baby without preoperative associated major associated anomalies, we can do also, depends on the type of defect from the anorectal malformation. Not everybody, if you want just fistula small one, you can do a little bit of small procedure here, cutback. It's a bad operation for a good surgeon, but you can do it just to release intestinal obstruction associated. And then you are not damaging the sphincters. You are just it's a mini, just not a wide, just open, increase the size of that fistula. And then later on you can go ahead, depends, because also going and operating on those low type, which you call low type, don't call it anymore, the perianal fistula, they're sometimes associated with other anomalies also, the whole pre-sacral mass. So take care about going directly to operate what you think it's a easy operation, but sometimes it's a complicated, becomes a complicated operation. Thank you.
Last question from Dr. Ben Saleh again. For long gap atresia, and if tracheoscopy was done, can we close the fistula using biological glue in order to avoid thoracotomy? لو فهمتك كويس دكتور بن صالح, if I understand you, يعني you are speaking about the case of type B esophageal atresia, الكيس اللي يكون فيها proximal fistula. هنا في البروكسيمال فيستولا I think it's not described to use glue. What is described is to do cervical incision and to close this fistula. This seems more safe, but theoretically your approach is not false. It can be possible to perform it. It will not avoid you to make thoracotomy, but make cervical incision. مش thoracotomy, cervical incision. خاطر هنا your approach would be close this fistula and perform gastrostomy and perform after your anastomosis. هذا فقط اللي أقدر أقوله لك. أتمنى أن يكون فهمتك كويس.
لا السؤال إنه هو كان for long
ايوه for long gap.
esophageal
سؤاله for long
atresia.
gap esophageal atresia.
long gap.
ايوه for long gap esophageal atresia.
Okay, long gap, but sometimes there's an upper fistula or a lower fistula. Okay, precise which type. I showed previously the ENT states with reference center, they start to do closing the fistula with those previously glued just temporary. Then with the catheterization of the fistula opening, they found that something improved. خاصة في اللي هم يكون شوية لكن في low type you need to do surgical procedure. Okay. Or if there's a fistula, you close it. في gap, feeding gastrostomy, close the fistula, and that's all. And then wait and see. Depends. You want to do the wait and see. You want to preserve the native esophagus, or you want to do esophagostomy. Depends on your environment where you work and the experience of the surgeon who want to deal with this pain. Okay. Thank you.
Another question, what the best management of esophageal stricture post primary anastomosis when failed endoscopy dilation? Dr. Aziza. Thank you very much Dr. Aziza for this nice question. يعني صحيح الأول option if we have stricture post primary anastomosis هي حتكون البالون dilation. We will repeat this balloon dilation, but if it's failed هنا في عندك two options. في عندك الاوبشن الاولى اللي هي stenting, esophageal stenting. هي حقيقة option كويسة. ليش الاسophageal stenting can be more efficient than the balloon dilation؟ الخاطر we will use a device which is equivalent to a permanent dilation. يعني دايما حيكون في permanent dilation. And you should take off the stent after 3 or to 6 weeks, and it can be more efficient. Otherwise, لو لسه في مشاكل ولسه الستينوزز موجودة والبيشنت symptomatic, here you will perform resection anastomosis. لو المشكلة متاع ستينوزز ما هي يعني wide، يعني لو صغيرة 2-3 سنتيمتر، يعني you can perform another anastomosis. وإلا في بعض الأحيان نضطر to make esophageal replacement using يعني colon, using stomach, using sometimes for some teams the intestine, the small intestine. بس الحقيقة اللي في العادة البالون dilation can be sufficient to treat this patient successfully. في العادة البالون dilation وحدها. احنا في الاكسبيرينس بتاعنا في المونستير يعني very rare case، في كيس فقط استحقينا نعمل له ستنتنج، عندنا البوسيبيليتي تو بيرفورم ذا ستنت، وفي مره وحيده فقط، مره وحيده على حالات كثيره اضطررنا باش نسوي ستنتنج، ولا مره في الحقيقه ما عملنا ريزكشن انستوموزس والا عملنا اوزوفاجال ريبليسمنت. نحكي بالطبع نحكي على بوست اوزوفاجال اتريزيا، ستينوزس بوست اوزوفاجال اتريزيا. شكرا جزيلا على السؤال دكتوره.
بالنسبة للإزوفاجيال structure depends على length of structure. Is it a short structure or a long segment structure? So the preoperative study give you an idea. I don't know if for a long segment the balloon dilatation will give a result. If it's a short, I think maybe it can give us a result. So it depends. Those long segment strictures, sometimes they need surgical interposition. That's what I can say about it.
شكرا جزيلا دكتور فريد. حقيقة كان ويبينار ممتع جدا. الحقيقة أنا فرحان كثيرا أولا لفما يعني وجود لأطباء تونسيين وأطباء ليبيين young residents. هذا شيء يفرحني جدا. زي ما قلت احنا أهل احنا شعب واحد، وهذا شيء يعني يشرفني. ثاني شيء اللي فرحان به كثير هو number of question, very interesting question حقيقة تنم عن ذكاء. الريسبونسز اللي شفناها في يعني بعترف اللي ما كان كويز صعب، بس الريسبونسز كانت كويسة. يعني كان في نشاط وحركية. أنا فقط عايز أقول اللي نعرف الفترة هذه فترة صعبة، وفي كثير من الشباب نحسهم محبطين شوي. يعني حتى في تونس نفس الشيء مع ريزيدنس بتاعنا، يعني كورونا ومشاكل والاكتيفيتي نقصت شوية، ويحسوا ممكن التدريب أقل والفورميشن أقل. بس هي سبحان الله، يعني على قد ما تكون الظروف صعبة على قد ما تكون الرياكشن أكثر، وعلى ما تقد إن شاء الله الأوبورتونيتيز تكون أكبر. يعني دايما الظروف الصعبة والأوقات الصعبة تليها أوقات رخاء وأوقات إن شاء الله متاع تقدم وكل شيء. أهم شيء هو في الحاجة هذه هو اللي يكون عندنا دايما الأمل. الأمل هو أكبر سلاح نقدر يكون عندنا في الفترة هذه. حتى راهو حتى بالنسبة للكوفيد، لو حتى إنسان مريض بالكوفيد وعنده الأمل، حتى في دراسات تثبت اللي هو علاجه يكون أسهل ويكون النتيجة أحسن. نفس الشيء بالنسبة لنا احنا لازم نخلي الأمل. انتم ما شاء الله ناس أذكياء، وبقدرة الإله حتكونوا أحسن منا. هذا هو الهدف، راهو هذيك سنة الحياة. يعني اليانج ريزيدنت حيكون أحسن من السينيور بتاعه، هذا مفروغ منه. بس لازم يكون عنده أمل، ولازم يدرس كويس، ياخذ بالأسباب بالمسببات، يتدرب كويس. يعني تو انتهت الفترة اللي واحد يشدك من إيدك ويقول لك تعال عشان أعلمك. لازمك أنت تسوي المجهود عشان تتعلم، تسأل أسئلة، تتقدم. وزي ما قلت لكم الأمل والعمل هو اللي حيكون إن شاء الله سر نجاحكم. وأنا متأكد، عشان أعرف أنا زي ما قلت لكم الجينات في ليبيا وفي تونس كويسة، يعني ناس أذكياء، هذا أقدر أقوله لكم يعني، فهمت؟ وإن شاء الله مع المستقبل حتشوفوا الأمور تكون كويسة، وبقدرة الإله حيكون المستقبل عندكم إن شاء الله. شكرا جزيلا مرة أخرى دكتور فريد، دكتورة أروى، شكرا جزيلا زاد الدكتور حبيب سبيس عشان التنظيم اللي صار. يعني إن شاء الله نلتقي قريبا. زي ما قلت لكم أنا من الآن يعني استدعيكم، يعني اعزمكم عشان تزورونا في تونس. حيكون شرف كبير لينا. اعرف اللي في ليبيين يعرفوا تونس اكثر مني، يعني ما شاء الله. يعني ان شاء الله لو تزورونا حيكون شرف لينا، وان شاء الله نقدر نسوي حتى شويه من الواجب. انتم اهل واجب ونعرفكم اهل كرم، احنا ما نقدر نكون زيكم، بس ان شاء الله نسوي حتى شويه منه ان شاء الله. وشكرا جزيلا مرة أخرى، وإن شاء الله تتعاد في مناسبات أخرى. أنا زي ما قلت لك دكتور فريد ومن عشر الشباب الموجودين مستعد لو عجبتهم. يعني أنا بالطبع ما عايز أفرض نفسي، لو المحاضرة عجبتهم والتقديم عجبهم نقدر نسوي يعني زي سايكل متاع محاضرات. وأقدر كمان أطلب من زملائي أصدقائي سواء في تونس أو خارج تونس اللي هم يساهموا في المحاضرات على حسب طلب الشباب وعلى حسب متطلباتهم. أتواصل معك دكتور فريد وأتواصل مع دكتورة أروى لو في طلبات. أقدر أسوي مثلا المرة المقبلة انتسيبشن، يعني ممكن حتكون حتى الفترة شورت أكثر، يعني مو تكون محاضرة بتاع ساعتين 3 ساعات عشان ما يملوا، حتى ساعة ونصف والديسكشن. وفيها ممكن لو فيها إن شاء الله يعني فيها إضافة حكون سعيد جدا إن شاء الله.
أشكرك دكتور.
بارك الله فيك دكتور.
شكرا لكم.
أمين على الكلمات القيمة تجاه الزملاء الليبيين، ونتمنى في التعاون معكم وتساعدونا، خاطر احنا عندنا جاب في التيتشنج بروجرام والحاجات هذه نتيجة قلة الدكاترة اللي متعاونين في المجال وإعطاء المحاضرات، وفي امتحانات قادمة قريبا لهذا الشباب حتى هم قاعدين مضغوطين، لكن اللي علينا نديروا فيه والباقي. ولهذا نرحبوا بالفكرة انك انت تساعدنا، حنرسلوا لك مجموعة محاضرات لو تقدروا تساعدونا من ناحية المحاضرات فيهم حتى يتمكنوا ان هم يخشوا الامتحان يكونوا على استعداد. قبل عندنا امتحانات، في امتحانات استثنائية دايرين لمجموعة الطلبة اللي هم كانوا يشتغلوا في جراحة الأطفال لفترة معينة كي 10 سنين 7 سنين 5 سنين، لهذا خذوا الكورس بتاعهم باش ياخذ دبلومة كانت عليه فترة 18 شهر قليلة بالنسبة إن هم يبدأ عندهم to gain diploma في pediatric surgery بالبيريد هذه it's not enough. لكن وزادتها الفترة بتاع ما فيش الشغل اللي هو البراكتس سيرفيكال اوبريشنز والحاجات اللي تيجي الكورونا، ولهذا أغلبية العمليات موقفة إلا الحالات الطارئة بس. ولهذا في ثقل. إن شاء الله يكونوا مستعدين إن هم نتمنى أن احنا نحصل مجموعة جديدة من الشباب اللي هم يتولوا قيادة الراية. احنا خلاص بنقعدوا ونقعدوا ممكن نساعدوهم اللي نقدر عليه، لكن لابد يكون جيل متمكن باش انه هو يتولى المسؤولية، خاطر هذه مسؤولية بينه وبين الله. انك انت بتطلع دكاترة لابد يكونوا على المستوى المطلوب، هي مش شهادة بس كي على أساس ياخذوها. لهذا اللي تشبه فينا احنا نعطوا محاضرتين 3 في الأسبوع باش نمشوا بهم شوية قدام في المحاضرات، هم يقروا بروحهم، لكن الدراسة الواحدة لابد تبي معها جهد ثاني. إن هم في حاجات معينة مرات بالاكسبيرينس الواحد they will not gain it from test books or lectures. إن شاء الله يا رب يكون في عونهم. إحنا دعينا نديروا فيه ونبوا مساعدتكم في كل حاجة.
ان شاء الله ان شاء الله ان شاء الله.
اللي تقدروا تعطونا بعدين انتم ردوا علينا، تقدروا تساعدونا ولا احنا نستمروا بالمشوار بتاعنا ان شاء الله. في نفس الوقت احنا مرحبين بكم، عندكم اوقات فراغ، واحد تحدد لنا الايام والوقت والواحد، واحنا we are waiting for the help from everybody.
يا دكتور فريد ما تقول هيلب، احنا بنساعد بعض، بس والله انا بتعلم كثير. انا من ديسكشن زي هذه زي اللي صارت بحب كثير هالديسكشن هذه، ولا من الاشياء اللي قدمتها دكتور فريد انا بتعلم معناتها الناس كل بتتعلم مع بعض. راهو بالعكس هذا كويس، هذا كويس جدا. انا في الاخر رابح معناتها.
بارك الله فيك.
شكرا
ونشكر
جزيلا. ان شاء الله القاكم بخير.
الزملاء من تونس اللي شاركوا، وان شاء الله نشوفهم من تقدم للتقدم. نشكركم، شكرا.
ان شاء الله. وان شاء الله ححاول اعمل تسجيل و I will share with الدكتوره اروى ولا دكتور فريد، وحطه في الجروب فيسبوك معكم بالنسبه للمحاضره هذه، وكمان الفيديو اللي قلت لك عليه ان شاء الله دكتوره اروى ان شاء الله. شكرا جزيلا مره اخرى.
شكرا دكتور، بارك الله فيك.
شكرا
مشكور جدا. شكرا على وقتك. شكرا.
الصوت اتقطع.
بارك الله فيك.
ما نسمعش فيها.
هو الصوت اتقطع بس فهمت
كهرباء.
شكرا جزيلا. شكرا.
هذا نقول لك كهرباء يا دكتور امين.
مشاكل في الكهرباء ان شاء الله.
انا مولد تو اللي يشتغل كمان في مناطق فيها مشكله كهرباء. الحمد لله اللي حصلنا محاضره وتمت الحمد لله.
الحمد لله الحمد لله. خليك بخير ان شاء الله. السلام عليكم.
السلام ورحمه الله.
تصبحون على خير. تصبحون على خير.